Hi, everyone. Welcome to another one of our fantastic Take Action webinars. We are so glad to be here with you today. I'm Kristen Soul, and I'm a pediatrician at the University of Missouri, and I'm also the executive director of ECHO Autism Communities. What we do here on ECHO is we imagine communities where all people with abilities are able to live their best lives no matter where they live. And that means they have access to best practices in their healthcare, in their schools, and in their communities. And so I'm super delighted today to be able to talk to you about what autism is and also what an evaluation for autism looks like. We have a great team of experts that are here with me today, and I'd love for them to introduce themselves as well. So Melinda, if you would start us off.
Hi, my name is Melinda Odom, and I'm a licensed clinical social worker, and I'm also the training manager for the ECHO Autism program.
Great. Alicia?
Hi, I'm Alicia Curran. I am the mom of a 20-year-old with autism, and I'm also the director of operations for ECHO Autism Communities. It's great to be here.
Great. Thanks, Alicia. All right, Val?
Hi, everyone. Valeria Anclares, Val is fine. I'm a licensed clinical psychologist, specialized in neurodevelopmental disorders and autism for many years now. And I'm part of the ECHO Autism team. I am the director of program development and global expansion. So very happy to be here.
Today, we're going to be talking about the signs of autism and also those symptoms. It's a broad spectrum. So both Val and I are going to be talking about that together. We're going to show you a little bit about the history behind autism and where it first was kind of conceptualized. And then we'll talk through the different signs and diagnostic symptoms of autism. And then essentially what it looks like to be diagnosed or evaluated for an autism spectrum disorder. And then we're going to open it up for some questions. We've got some questions that have come to us, and then also those of us who do this all the time get lots of questions from our community and certainly many families that we've helped along the way. So we're excited about that. So let me share my screen. I'm going to start us off. It is important to know that both Dr. Anclares and I have a lot of clinical experience in doing this work, but we also have a large role in our field in helping to support the evidence-based best practices around the evaluation of children with autism. And that includes innovations. And so, for example, I do help in several different ways with organizations that are also trying to innovate to bring new innovations to the care and the evaluation of people with autism. So that's an important thing to understand. So that includes things like Cognoa, Quadrant Biosciences, and Autism Speaks. And so all of those are important. And I know Dr. Anclares does it as well. Do you want to share that?
I am participating in consulting with some of these projects, but in particular, I'm very involved in diagnosis. And so I'm a certified ADI and ADOS trainer, and I do this both in the US and throughout Latin America. So yeah, it's part of my role in trying to create access.
Yes, absolutely. And I think that's an important thing. We're going to talk a little bit about what those acronyms are. So the ADOS and the ADI, we'll talk about that later. But you'll hear, we try really hard not to use a lot of jargon, but you know, there are a lot of alphabets in the alphabet soup of some of the things that we do, and we'll do our best to make sure that we explain those to you as we go. So here we go. We're going to take a look at autism across the lifespan and help us to really think about those signs and symptoms so that all of us can have a better understanding of what autism looks like. Because I think the more we understand what the symptoms are, the more we can start to think about it in that broad spectrum and understand people and all of their abilities, because it isn't just one, you know, picture. And I hear this a lot, like, oh, I know that's not autism, or that is autism, or that's not what I thought autism looked like. But a lot of people don't really even know what autism is, right? And so I think the more we understand and the more we can really communicate and be accepting of all of the abilities, I think can be really helpful. So what is it, right? So autism spectrum disorder is a neurodevelopmental disorder. So neuro, brain, developmental means starts early in childhood. And so that affects the brain and starts early in life. We have a lot of different ideas about whether it could be before birth, so while growing inside the mother's stomach, or after, right? So we don't know for sure exactly when autism is first starting to develop, but there are a lot of different research ideas that are helping us to decide and to learn when that starts. But we do know that the symptoms manifest or start in a couple of core areas. So social communication and repetitive and restrictive behaviors. And we're going to really get down into the weeds of what those exactly mean, right? Because if somebody on the street just walks up to you and says, what's social communication? And you've never heard of that before, that may make no sense to you. So we're going to break it down and really help to understand what that looks like. But you also might find it interesting, and don't worry, we're not going to go into a huge history lesson, but the history of autism is kind of interesting. It didn't exist until the early 1940s. And so it was first recognized by Dr. Leo Kanner, depending on how you want to say it, and Dr. Hans Asperger. They recognized that autism was different from schizophrenia or psychosis. And they both used the term autistic. There was a really seminal study that was done in the early 1940s, again, defining some case examples of 11 children that really started to define the term autistic. And that was the term originally used in the 1940s. That helped us to see this extreme aloneness that these particular individuals, these 11, had, as well as atypical language and communication, repetitive noises and motions, and this obsessive desire for sameness that were very distinct from the other types of mental conditions that had been described to date. So the schizophrenia and psychosis at the time. So here are what the changes looked like. We went from that group of diagnoses, the autistic disorder, Asperger's, PDD-NOS, to a single category of autism spectrum disorder that helped to capture that breadth of individuals who are on the spectrum. We went from 3 symptom domains to 2. That's going to be a little less relevant to many of you who are listening, but that's still an important thing to understand because we had learned so much about autism in those couple of decades that it helped us to really get down to what exactly is autism and how is it different from other things. That helps us to really clearly define it and to help better understand how we can help those that are diagnosed with autism. And we also added, or the DSM-5 also added a severity level to help to characterize the differences that we see clinically on the spectrum. Because there is this big word that we use, heterogeneity, which just means there's a lot of differences within the spectrum. And I think that's what we see in a lot of what we're going to talk about today. So how common is autism? Autism is definitely something you hear about on the news. You see it in, the media. You might see it on People magazine if a celebrity is talking about their child who has autism. But I can tell you that these numbers are also reflective and anchored in some of the history that I just shared with you. It didn't show up in our diagnostic manuals, the manuals that we use as professionals, until the 1980s. And as you heard, the science of what we were studying and learning about autism really wasn't happening until the mid to late 90s and the early 2000s. So as we learned more and got better and better at understanding autism, the prevalence also increased. Now, that definitely is not likely to account for all of the increase. However, it does account for a lot. We also got much better at tracking who was receiving a diagnosis. So these CDC numbers, or the Center for Disease Control, has been doing a nice look at this number over time. And so our most recent data tells us that 1 in 54 8-year-olds in the United States that are used for this purpose, that data is used for this purpose, have an autism diagnosis. And so autism is a spectrum. You're going to hear us talk about that a lot. And so it's deficits in social communication and interaction, and the presence of restricted and repetitive behaviors. But again, it's a spectrum, and you're going to see variation between individuals, and among those same within that individual, you may see a spectrum of the same type of behavior. And so, for example, there may be differences among a group of individuals who have autism spectrum disorder. And then that same individual may change over time. So as we talk about autism and what it is, we'll talk a little bit about that. But it certainly adds to the beauty of the people who have an autism diagnosis, because they're really very, very different from each other and have their own abilities within this group that we call autism spectrum disorder. So we're going to get down into a little bit of the detail about how this disorder that we call autism gets diagnosed. So let's hang together a little bit, because if you're a parent, this is stuff you might be like, whoa, this is a little deep. If you are a clinician, this may be something that it makes a lot of sense to you. Either way, hang in, because what we're going to try to do is really help you understand exactly what we're talking about, right? Because some people are like, how in the world can a doctor say that my 18-month-old has autism, right? We're going to talk to you a lot about how that looks and where we go from here. So at its core, these are the criteria. There's a lot more to it, but these are the criteria. So it's deficits, which is a word that's tough to swallow sometimes. So it's things you can't do related to social communication and social interaction. And then it's the presence of, or the repetitive, the restricted, and stereotyped behavior. Kind of interesting words to use that we'll break down here in a little bit. The symptoms have to be present in early childhood. That's a really important piece. They cannot have just popped up out of nowhere as you are a teenager or an adult. You have to have these symptoms as a child because it's a neurodevelopmental disorder. So that's an important piece as well. And then symptoms cause clinically significant impairment, right? So these are things that are affecting someone's daily life. And the symptoms cannot be better explained by an intellectual disability. Because the thing is, we know that there are other diagnoses that may overlap, one of them being intellectual disability. So our job as clinicians who are evaluating individuals for this type of diagnosis is to make sure that there isn't something that might better explain what's going on. One of those is intellectual disability. And so that's certainly something that we consider when we're evaluating people for this diagnosis. So what exactly is social communication, and how do you figure out if there's something that's lacking if you can't see it, right? So this is what makes evaluating a child for autism fun and challenging. So when we look at this is, you have to essentially be able to spot something you can't see, right? So that can be fun and challenging. And so deficits in social communication or social emotional reciprocity is something that we're going to focus in on here. This has to do with how we approach others to interact in a social way. So when I approach a friend, I'm likely going to be using my hands. I'm going to be doing all sorts of things because I'm a pretty gregarious person, right? But there's a range of this within all of us that we naturally develop over time. However, people with autism have a range of deficits within this category of kind of interacting with others, and they have abnormal social approaches. But they're also, this may vary. So when I'm evaluating a child or Dr. Nunclares is evaluating a child, we may also see failure. So when we look at this, we're looking for deficits in social emotional reciprocity, ranging from abnormal social approach, like a little bit odd in how they approach others, or failure of a normal back and forth conversation. So we'll talk a little bit about that. Reduced sharing of interest and emotions, to failure to initiate or respond to social interactions. Those are some tough words to swallow, but that's what we're looking at when we're evaluating these types of symptoms. It doesn't mean that person is a failure. It doesn't mean that person is always going to have these deficits, which again are tough words to think about when you're looking at a child. And yet, when you think about what a child can do, it can be pretty helpful to understand typical development. What we're going to do now is show you a couple of clips from public sources. So these are on YouTube. And so we're thankful that parents have shared examples of their children to be able to show us what toddlers can do. And so when we look at child development over time, we see the natural development of social skills, social communication skills. What we're going to see here is, again, publicly available. I don't know these children. I don't know these parents, but you can find on the internet amazing examples of the things and the communications that little people can do. These little guys are probably between 15 and 18, maybe 20 months of age, but let's watch for just a moment the things that they can do. And then we'll continue to talk about some of the things that we see in relationship, some of the deficits that we then look for when we're evaluating for autism. So we'll stop there, but I would encourage you to think about these two little people. They're, I think, twins. I think that they're having a conversation. How do I know these things? I'm watching their behavior, right? I'm watching them use gestures to point to their lack of a sock on one. They have changes in their facial expressions. They have change in their tone of voice. They're using their hands to communicate with each other. They're doing all sorts of things to communicate with each other. They're not using any words, and yet they're using all sorts of sounds and things to socially communicate with each other. So when I'm seeing a child, again, these are little people, right? They're standing and they're ambulating, meaning they're walking around, but they're not very old. They don't have a lot of hair. So as a pediatrician, I'm very, very well versed in knowing how to figure out how old a child is based on what they can do and very little other information. And so when I see them, I look at, oh my heavens, look at the great things in the social communication that these little people are doing. So then when I start to think about autism and I start to think about, okay, well, could this child be deviating or showing red flags for autism? That's what I'm looking at. I'm looking for how does that child interact with their mom, with their dad, with me, with their sibling? How are they interacting with other children if they have that experience? Sometimes they do, sometimes they don't. However, what we know about child development is that as that child is developing, even from the earliest of ages, they know as a human baby, how to interact. They're starting to coo, they're starting to make eye contact. There's a lot of that natural development that happens. And so certainly when I start to see those babies over time, as they get to be toddlers and then little people and, they're growing through their development, you can see those stages. And so certainly then as I'm seeing them as part of these evaluations, which we'll talk about, you can certainly start to see these differences that can happen. And so certainly then organizing how they interact through verbal and nonverbal, using their hands, using their words or their approximations, we call them. So those little da-da-das that those cute little twins were using, those are probably them saying, I like to pretend that they're saying, look, I don't have a sock on. Where's your sock? I don't know. Or like, I don't know what they're saying, but that's what I think they're saying. And so they're communicating, they're clearly communicating with each other. But we also can see that sometimes kiddos have challenges with eye contact. And so that's something that we are looking for. What does that quality of eye contact look like? And how are they using their body language? So many opportunities for that social communication. But there can also be a lack of understanding related to how other people use their body language and their eye contact. So how a person with autism interprets someone else's facial expressions, eye contact. And that certainly is something we see in our older kids. And then this range also can include a child who may not have many facial expressions. Maybe they're always happy, or maybe they're always just kind of flat. Doesn't mean they're depressed, but maybe they have some of those things. And then certainly maybe not using many gestures. So you never know for sure what they're thinking or feeling or what they want. So maybe they just cry and you're not sure. So you're always guessing. These can be really big challenges in this space. And so certainly what we know about a typically developing little person is that they do tell you in different ways what their needs are. And so as they grow and as they develop, those are important things. Here we're going to look at some real itty bitty little babies. These little ones, again, publicly sourced information through YouTube. Thank you to the parents who are willing to share. And this is certainly something that I think highlights probably around a 2 to 3, maybe 4-month-old set of twins. Most likely though, probably 2.5 to 3 months. And let's watch just for a minute this social communication at even this young of an age. So I adore those babies. And here are some of the things that they're doing. Eye contact, change in facial expressions, change in their tone. They're clearly having reciprocal babble or cooing, sorry. So that cooing is the vowel sounds. The babbling is the consonant sounds that'll come up about a month or 2 later in their development, but they're interacting with each other. That's social communication at its earliest stages. So when we start to see red flags later and us as professionals start to see like, uh-oh, we're not seeing some of the things that we would anticipate seeing at certain ages, it's because this is what we know should be happening all along the way. We do know that some people with autism may not have ever developed some of these skills, but we also know that some people do develop these skills and then lose them. And so those are certainly some things that we think about. The third piece to social communication is maintaining and developing and then also understanding relationships. And this ranges again from difficulties adjusting behavior to suit different social contexts, to difficulties sharing imaginative play or making friends, all the way to the other end of that spectrum, which is absence of interest in peers. You can see that's a big range, right? This could be everything from not knowing for sure how to adjust your behavior to kind of quote unquote fit into a certain environment. So kind of knowing what you're supposed to do in a certain context where everybody else seems to know that you're supposed to be, let's use the example of being quiet in a certain location compared to being noisy. The whole everybody else there seems to get it, but that person doesn't seem to catch on that's the expectation, that social expectation. That's one end of the range, all the way to the other end, which is just like, I'm good. I'm in my own world. Thank you. I don't need you. I'm fine. And they're not saying those things. Obviously, this is just this lack, an appearance of lack of interest in others. And I think that's an important thing to note. It's the appearance. We don't know that they have a lack of interest. They appear to show a lack of interest, at least on the outside as an observer. We're going to watch a brief clip of this. Also appreciate this also from a public source. These are two twins as they are playing side by side.
Hey! Hey!
So this, I think, is a really great opportunity for us to see the little one in blue is looking up at the cameraman, which we could presume is probably his father, kind of seeking his reaction to him stealing the little one in red's toys. He's grabbing and knocking down those blocks, and you could make the assumption that he's looking to the cameraman or his dad for a reaction. He's not really getting a reaction from what I would imagine is his twin brother in red. And the little one in red is continuing to just kind of go about his business, despite the fact that the boy in blue keeps stealing all of his stuff. And what you also need to see, right? So what I see is the lack of protest. There's not much saying like, hey, quit. Again, no words here, but even looking at his brother, like, I see you, stop stealing my stuff, right? Or like, do you mind? Like, I'm playing here. Or even looking to dad to say, hello, help me. Those social communications of natural progression of kind of what we would expect to see from a frustration standpoint. And so those are some things that when I look at a video like this, it does make me wonder about social communication skills and helps me think about how this little boy is demonstrating social communication skills. And so seeing them side by side, you can see that difference in eye contact, in social reciprocity. And then also we can start to see some of our next categories. So thinking about repetitive and restricted behavior, he's stacking those blocks. He's really interested in stacking those blocks, and he's not really perturbed by much of anything. He's just gonna keep on doing his block stacking. And so those are certainly things that we would be thinking about. So that second category is a little easier because it's seeing what you see. So it's restrictive and repetitive behaviors. And so sometimes the word we use is stereotyped or repetitive motor movements. Sometimes people call these stereotypies is a word you might hear. That means things like hand flapping, finger flicking, finger twirling. They're all types of different behaviors. And to be honest, many of us have all kinds of little behaviors we do. You may know someone who twirls their hair. I pick at my cuticles. There's all kinds of things that we do. But what makes these distinct from others is that they tend to be very repetitive in nature. And they tend to be something that you'll see often, sometimes related to stress, but not necessarily. And so those are certainly things that we see And those are things that we are able to then identify as being a symptom that we need to keep an eye on and evaluate. In this category also includes lining up of toys, flipping of objects. Echolalia is a repetitive behavior. That's a big word that essentially means repeating sounds or words or phrases, although phrases get a little bit beyond the phrase of echolalia. But it's really looking at how we are using the sounds that come out of our mouths. So in a repetitive way is what echolalia is. So again, a little bit, there's more to it than that, but that's at least a decent start for us to be talking about. And then insistence on sameness. So just like the folks who identified autism in the 1940s, they recognized this almost obsession with sameness, this needing to have things be the same. It's not the same as obsessive compulsive disorder, but it's this, it's black and white. This is the way we do it. We're going to do it this way. This is how it happens. This is what we're doing. So it's inflexible adherence to routines, being very much like, nope, this is what we do. It's black and white. I do this, then this, then this, then this, and it will not change. The challenge is when you add that to social communication difficulties, that can result in serious behaviors, whether that be a meltdown, whether that be a tantrum, whatever. Those extreme distresses and small behaviors can be, or small changes can be really tough, because if your mind is telling you it has to be this way, it has to be this way, this is what we're doing. This happens, then this happens, then this happens, but you're having a hard time telling somebody that, well, there aren't a whole lot of choices in your mind except to have sometimes to have a fit. And so having, that understanding of how autism works and the way the mind of someone who has autism may work is something that's important for us to understand. So difficulties with transition are a natural effect of this. The more I'm stuck in something happening the way it needs to happen, the harder I'm going to have with something changing. So that transition, somebody saying to me, all right, Johnny, it's time to get up. We're going to the store and I'm not ready to let go of my toy or my thing. I'm not going to be too happy, right? And so difficulties with transitioning from one thing to the next. So we can see this manifest or show in lots of different ways. And so those are some examples. We also, though, can see highly restricted or fixated interests that can be abnormal in intensity or focus. So unpacking that a little bit, these can be things like really strong attachments or super duper interest in an unusual area or an unusual object. It doesn't always have to be unusual, by the way. So what we see sometimes in girls particularly, they may be just really interested for a very long time in something that the other girls were interested in but have moved on from. So they may have fallen in love with horses as a 4 or 5-year-old, and then they stay super interested in horses when all of the other girls have moved on to makeup and who knows what else, right? And so that's just an example, but there are many examples. And really what distinguishes this from just a deep interest, that all of us can have, is that it becomes so deep and there's not a lot of engagement with others. So it's someone who kind of gets stuck like a broken record on, let me tell you about Thomas, and they're not terribly interested in you also being interested in Thomas. It's more like, yeah, but let me tell you about this. But guess what? This is not bad. There's a lot of awesomeness that can come from these highly focused interests, because great things can happen when you are able to harness the interests and think through how those people's, children's, adolescents, young adults, highly focused interests can be used to help them learn, to help them find their passion, to help them do what have you. And it's also a joy to hear some of the most fun things that kids get really interested in. And so it's really neat. I could tell you stories for days about my patients that have the coolest interests that I've gotten to learn from them. And I'm sure Val can as well. And so those are certainly really cool things. However, it is important to identify autism early. And here's why. Because we want all people to have an opportunity to go on to learn in school, to go on to have the chance and the ability to lead their best lives, whatever that looks like. So if that means that they love sorting different types of screws at the hardware store because that's their passion, fantastic. If it's that they absolutely love computers and they want to go to the engineering school and learn how to make a computer and make the next greatest software, fantastic, right? But here's what I know. Early intervention matters. And in order to get to early intervention, we have to have a diagnosis. That's the way our system is currently organized. And so getting us to an understanding of what autism is and early matters. So what we're going to see here is, again, another publicly available clip that is important for us to know. I don't know this little boy. I don't know I have no idea if he has autism or not. But when I watch this, I'm going to tell you that I see things that are concerning to me. And I see things that if I were to see him, I would say, we need to act now. We need to act quickly, because early intervention will change the trajectory of how he can lead his best life. I don't know what his best life will look like, but I do know that getting him early intervention will allow him to reach his best life, whatever that might look like. So when we watch this, be thinking about some of the things that we talked about as far as social communication, how he interacts with his mom,
Carter,
and the repetitive behaviors that you're going to see.
Carter, 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 can you look at mommy? No. Here, play with this. That's different. Play with that.
So we'll stop there. However, I want to highlight a few things. This little guy is not walking yet, so my guess is he's probably around 10 months, maybe as old as 14 months, but probably not based on some of the things that he's doing. So he's little, right? But what is he struggling with? What are the things I'm not seeing? I'm not seeing him respond to his name. I'm not seeing him make eye contact. I'm not seeing him reference his mom when he is looking for different toys or when something falls off his finger. I'm not seeing him show any interest in anything other than something circular. I'm seeing him showing spinning. He likes to watch that little spinning donuts. I'm seeing an entire room lined up of all sorts of objects that he could play with on the walls. If you watch the video further, you know, he's got a walker, he's got a this, he's got a that, and he is sitting by himself playing with circular objects that he can spin on his finger. This little boy needs early intervention, and he needs it now. And this is something that's incredibly important for us to recognize and not wait. We take action. We take action because he deserves to live his best life. We don't know what that will look like. We don't know whether he has autism or not, but we know that standing up, saying something now can change what that will look like moving forward for this little person. And so when we think about this as a parent, when we think about this as a professional, yeah, this stuff is hard, right? I'm sure this mom is thinking, why isn't he responding to his name? And yet the pain of him not responding to his name will only be made worse by someone not helping her figure out how to help him respond to his name. And so just ignoring it, as sometimes professionals may feel like they need to do because they don't know what to say, or a friend may think that, oh, I'm not going to say anything because I don't know what to say. That is only a temporary pain. The bigger pain is just saying nothing and allowing it to just go unnoticed. We have a chance to do something, to take action and do something that makes a difference for children like this. So when we continue to think about what are the symptoms of autism, the last category is a very interesting one, and it still falls within this restricted and repetitive behavior. And we think about it as sensory. So interestingly, there's a broad spectrum here too, right? What's the theme for the day? Broad spectrum. So some people with autism have hypersensory reactions, meaning they might be sound sensitive. So they're like, oh, too loud, too loud, too loud. And then in other ways, in the same person, they may be hyposensitive. They may say, I just broke my arm. I got a bone sticking out of my arm. Is that a problem? Not joking, had that happen. And so in the same child, Ow, flushing toilet, too loud, hypersensitive. Bone sticking out of my arm, is that a problem? Yeah, right? Hypo, that's undersensitive. That's high tolerance to pain. That would be a hyposensitivity to pain. It gets confusing how the wording it happens, but in the same person, right? This is also how some people on the spectrum explore their environment. So licking items or sniffing or smelling or, exploring somebody. One of the abnormal social approaches I often hear is that, my child likes to lick new people's shoes. Interesting. That's an unusual social approach, right? It's also an abnormal sensory exploration. Those are two different things, but they're both symptoms, or those fall within the autism kind of domain here. And so those are things that we think about. But we know that that is part of the spectrum that we're understanding and trying to figure out, how is it that we have hypersensitivity to sound or sight or this or that, and hypo reaction to pain within the same person and different from one person to the next, but yet they have autism, right? So that's where active research continues. And that's where active engagement of people all across the spectrum, wherever they live, is so vital to the work that we do and the work that all of us as communities need to be helping to engage in so that we can better understand it. I know that when I'm taking care of patients, every kiddo that I see, or every person that I see, because I do take care of adults as well, they're all unique. They all have their own gifts and their own talents and their own abilities. But I can't always explain why one is this way and one is that way, and why one got all of these interventions and still is really struggling versus one who got almost no intervention and is doing great. I can't explain all of it either, right? So we continue to seek those answers. We continue to take action and apply the knowledge we do know so that we can continue to learn and work towards that community where all people with all abilities can lead their best lives. And that's what's so important about us continuing to march to that drum so that we can get there. So this little guy is going to show us a little bit more about some of these sensory behaviors that we're talking through. Not a whole lot here, but then we're going to shift into some of the work around how do we actually diagnose this. So I love this video. This is a long video that you're all welcome to watch on YouTube. Again, I don't know any of these folks, and so I'm so thankful for the parents that have shared these types of examples and continue to try to help others understand autism in different ways. So those that share this type of information on public sources, thank you, right? Because it allows me to be able to bring to life what autism is, right? As a clinician, I can't just show pictures of my patients. And so those of you who are willing and open to sharing on public sources, allow us to bring to life a little bit more of what we see every day. And this little guy is adorable. And so certainly helps us to kind of see some of those sensory behaviors, the jumping on the trampoline over and over again, some of the lining up of things. But those are some important things for us to understand. But at the end of the day, we're going to get to, I love that music. At the end of the day, so much of what we get to see is the abilities that each of these children and young adults and elderly, don't forget, who have autism can do. There's so much they can do. And so it's not about defining somebody as autistic or saying, oh, what I didn't know, somebody with autism could do that, right? Because that's what I hear a lot. Like, well, they have autism, they can't do that. Well, who said? Right? And so thinking about what does that mean? And so what we're going to do now is shift gears a little bit and talk about how do we as professionals, right? So that's what Val and I are. We're experts in our field. We teach other people in our field how to diagnose autism. And so we're going to drill down a little bit on that because we know there are a lot of questions. And then we're going to still take a couple of questions and answers and talk through a little bit more about what this looks like. And so we'll go from there. So I'm going to turn it over to Val for us to talk about best practice autism evaluation. So Val, over to you.
Thank you. And I think it's so important. The last, well, everything was important, but this last aspect of not using this as a label, right? And it shouldn't be a label. It should actually be a description. And the evaluation process allows us to describe that person or that individual so that then we can provide the right intervention. The sooner we do this evaluation and the more information we gather about someone, the more we can help that person figure out what are those areas of strengths and weaknesses. How can we, and I know some people don't like to talk about weakness because it sounds like something static. So it's more like the differences that they're showing, and how can we lean on areas that are areas of strength, areas that are functioning well within their age level and their ability level, and bring some of those other areas that aren't developing as well up to snuff. So the evaluation helps us understand, it helps us provide a diagnosis, because as Dr. Soul said, without an appropriate diagnosis, we can't have access to those services that are so important, whether it's in the school or additional services in terms of outpatient centers. So what do we, when we talk about best practice autism evaluation, what does that mean? And we have certain things that we kind of at a minimum do, and then other things that we add depending on what the referral question is or what the challenges are. At a minimum, we do need a good history. The diagnostic criteria states that this is something that needs to be there from an early age. So if we're seeing an individual who's 6, 7, 8, 10, 12, 15, an adult, we still need that early history. So we're going to get everything about current functioning, but it is very important to understand how those characteristics developed. When did they start? In what context? So not just the characteristics themselves, but also the development of those characteristics, the generalization of those characteristics, and in which context. That helps us understand if this it has to do with the autism spectrum or some of the other neurodevelopmental disorders that have many characteristics that overlap with autism spectrum disorder, and we need to be able to do those differentials. So at a minimum, we need that thorough developmental and comprehensive medical history, including how it developed and current functioning. We also need direct observation. So usually we get that thorough developmental and comprehensive medical history from parents or from the caregivers that allow us to understand what that looked like early on. And then we have to do a direct observation. And there are some gold standard instruments that are used for that direct observation. Some of them are stated here. The STAT is a level 2 screener. The ADOS-2 is considered the gold standard. That's the Autism Diagnostic Observation Schedule. And then the Childhood Autism Rating Scale is also a screener that we use. But let's not forget that all of us have been trained, and a part of our, the most important aspect of all of this is how do we interpret this information? So we can't forget our clinical expertise. We need to bring all this information together that we've learned from the parents or caregivers or teachers or others that are part of this individual's life and our direct observation. And with that, really determine whether those diagnostic criteria that need to be met in the social communication domain and in the restricted and repetitive behaviors, does this individual fit those diagnostic criteria to be able to say ASD? So it's really important to keep in mind that we need all that information, but we still need to have clinical judgment, right? We need to bring it all together. So based on the level of symptoms, we're going to have a multidisciplinary team assessment. That is the best case scenario, where we're looking at other areas of functioning like intellectual abilities and language abilities and sensory motor assessment. We really need to understand, are any of these things better able to explain some of the differences that are noted and why the parents or the individual came for an evaluation in the first place. Next. As the child grows, as Dr. Soul was mentioning, so do the complexities, right? And what we need to consider might be more comprehensive. We might really need to look at a variety of different things to help us clarify what the diagnosis is. From intellectual abilities, we might have to assess directly there are many myths about, the how many individuals with autism also have intellectual disability. And I think people tend to assume that all individuals with autism or most have intellectual disability, and it's actually quite the opposite. Only about 30% actually have intellectual disability. There's another about 20 to 25% that have kind of borderline intellectual functioning, and the rest actually have intact cognitive abilities. So I think that's one of the biggest misnomers regarding ASD, is that they all have intellectual disability. So we really need to look at intellectual functioning, language abilities, adaptive functioning. This is probably what hurts individuals with autism the most as they grow, is that there tends to be a gap between their intellectual ability and how they're actually functioning. And this gap widens with age. So working on that from a young age is going to make all the difference. And then, activity level and some of the comorbid, meaning things that diagnoses that are associated oftentimes as individuals grow, have to do with ADHD or attention deficit, hyperactivity disorder, or some anxiety disorders, or some depression that tend to be associated. So all of these we need to sort of look at and assess as part of our multidisciplinary team evaluation. So the diagnostic process will always start with a diagnostic interview. We need to understand the history and current functioning. We need to understand how these, the things that are preoccupying people, the things that are concerning people, the things that are brought up as concerns. How did this develop? Did this develop all of a sudden? Did it develop over time? Were you noticing some things before, yet you were kind of explaining it because, my cousin Johnny did something similar, or my uncle didn't start speaking until he was a little bit older. And so lots of times there's a lot of explaining that happens around some of the differences that you're noticing. Once you get, go through the process of evaluation for your child, oftentimes all of a sudden you're like, oh yeah, okay, now I recognize that there were all these signs before, but maybe you weren't quite thinking about them, right? So the diagnostic interview helps the parent and the clinician be able to figure out that progression over time in terms of milestones, in terms of medical history. Was there anything around birth all the way to the present? Any family medical history? Are there other individuals in the family who have an autism spectrum disorder diagnosis or other neurodevelopmental disorders that help us understand what we're seeing? Social development, and then really looking at all of those areas that we talked about and that Dr. Soul went through in terms of what are those diagnostic criteria for the diagnosis of ASD according to our Diagnostic and Statistical Manual. Our current version is 5. The second piece to a diagnostic process is the direct observation, right? So it'll start with a good, solid diagnostic interview to help us understand what are the challenges and what are the strengths in a variety of different areas and over time. And now we get a direct observation. What are we observing today? So we have several measures that allow us to look at the different characteristics that we associate with the diagnosis of ASD. And these tend to be kind of structured behavioral observations that are really, really important. The ADOS-2, like we mentioned before, is the gold standard evaluation tool for autism, but there are others that are important and that allow us to really structure our observations in a way that we can really then inform our clinical judgment and our diagnosis. Everything that we obtain in terms of history and in terms of current functioning needs to be contextualized. We need to figure out, okay, if there is, for example, delays in language, how did that appear? When did that emerge? Were there always delays in language? Now, language is different from communication. We can have delays in language, yet be awesome communicators. So this is, for example, one of the main diagnostic differentials between a child who might be developing autism versus a child who simply has a language delay. The child who is experiencing more of the language delay without the ASD associated will develop a variety of different gestures to compensate for their lack of verbal abilities. And that's because communication is not affected. They do want to communicate, they don't have the words, so they will develop a large repertoire of facial expressions and gestures to be able to communicate. Whereas the child with autism, really what is affected is social communication. They don't develop that repertoire of gestures because they're kind of one step behind. They still need to understand that back and forth that is part of that social reciprocity that Dr. Soul talked about, that two-way street that happens so that I can understand you and you can understand me, right? So language, before we develop language, we need to develop communication skills. And that's something that's affected in ASD. So this is really important, in understanding all these behavioral observations and all of the developmental history and all the information that we gathered. It helps us for treatment planning. And that is really the most important reason why we want a diagnosis. We want a diagnosis so that we understand what we're dealing with and we know what the next step is, right? So the result of an evaluation is not the end of a process, it's the beginning. It's what leads us into the next phase of the process, the next part of the journey, which has to do with treatment and access to the right services and the right intervention. And that's what we really want to do through these webinars and so many other ways is create that access and make sure that that next step, everyone is familiar with what they need to do. So for a diagnosis, really what we're looking for within a diagnostic evaluation is both the presence and the absence of behaviors, right? When we look at the presence, we're looking at some of those more atypical things like the presence of those motor stereotypies that Dr. Soul was talking about, whether it's repetitive movements of the hand or repetitive movements of the body. We're looking at the presence of echolalia, repeating things, the presence of rigid patterns of behavior, or the presence of unusual sensory responses to different stimuli from the environment. But then we're also looking at the absence of behaviors that we typically do see, like the use of gestures or facial expressions or eye contact to help us in the communication process, right? The apparent lack of interest in peers, not knowing or not being interested in playing with peers. So there are certain things that allow us to look at these different behaviors, and these will be very different depending on age and IQ and language ability. It'll vary depending on culture and context, right? How we think about these things. When children are younger with an ASD diagnosis, we tend to see more of those overt, repetitive motor mannerisms and rocking and maybe clapping and jumping up and down. As individuals grow older and they learn to curtail some of them, not all, right? This is the spectrum. There's all these spectrums within the spectrum, right? But it may look a little bit different. The interest might be, really focused on a particular area of interest, and the presence of repetitive behaviors might be in the narrow focus on something and only being, interested in birds or train schedules or soccer matches or whatever it might be. So it's going to look a little different over time because, there's this constant interplay throughout an individual's life of the autism first impacting development. But then as the individual grows and develops, the development also has an impact on how the autism is presenting itself. And this interplay will be there for life. And so it will never look the same, and it shouldn't look the same because the individual grows and matures, and the autism characteristics change with that growth and maturity. And so the more we can intervene from an early age, we're helping to decrease the impact of that autism or those autism symptoms causing an impact on development per se. But it is a spectrum, and all these pictures represented here, it goes from, very minimal to maybe something much more severe. Language develops in And there's only about 40% of individuals with autism that do not develop language. Now, how much language and the level of language and the level of ability to use language to communicate will also vary within that other 60% that does become verbal. And so it is a spectrum, and we need to understand that not every individual is the same. So here are some links that folks can refer to that talk about the diagnostic process and talk about the signs and the early signs of ASD, and specific toolkits and parent resources that are really, really helpful.
Excellent. Thank you so much. And so we're going to stop there and have a chance to talk a little bit together from all of our perspectives, right? So here you have a pediatrician, a clinical psychologist, a licensed clinical social worker, and a parent professional who all have experience from our various roles and perspectives. And so, you know, I certainly really appreciate this opportunity to talk together about a really important topic. And so I want to start first with you, Alicia. Obviously, I've known you for years, so I know a lot about your journey, but would you mind sharing with us a little bit about not only your journey, but a little bit, I guess, a little about the journey, but more about kind of the now and how you've seen your son evolve over the years?
Yeah, thanks, Kristen. So my journey started out really rough because I didn't know anything about autism. And if there's one big takeaway I've had over the course of my journey raising a child with autism, which he's now 20, is that knowledge is really power. And autism looks a lot less scary when you're able to know what it is. And then the helplessness of not knowing how to help your child kind of fades because there are great resources and strategies and professionals who can help. So, you know, what started out as a devastated mom who couldn't even really say the word autism out loud without crying says it about 80,000 times a day today. You know, I think Sam's journey, Sam has, he's very affected by autism. He needs a lot of support to make through his day successful. And our family and fantastic educators and professionals are able to support him in that way. I feel like today, as you know, we went through that phase of here's the diagnosis, and now you know the treatments and the plans and the education and all that stuff. But now we're at a different zone where I find myself a little in the unknown again, and learning about what does adulthood look like for Sam. You know, pulling on all those strengths that we've seen grown throughout the years, although Sam has a lot of places where he needs a lot of support and a lot of help. The one thing I can tell you is my son is a very, very smart and caring individual who does his best every day and amazes me every single day. There's not one day in his life that hasn't gone by where I haven't seen a little miracle, something that he's not really shouldn't be able to do if you look at it on paper, but he executes it. So we've always tried to pull on those strengths and leverage on anything, maybe it's a restrictive interest or a narrow interest, and try to leverage those things into a strength. So again, I kind of find myself at this point trying to figure out what does adulthood look like for him. And I think my biggest goal, adulthood is going to look different for Sam than it is for me or any of us. And I think we can say that's true for everyone. But I want Sam to have a great quality of life. And that's always been my goal, is to have that great quality of life, and realizing that his quality of life is looks differently than what my quality of life looks like. So, you know, it's been a journey full of challenges, but I will tell you those blessings far outshadow the challenge. any challenge that we've faced. And he inspires me. He has autism plus a whole bunch of other things, and he wakes up fairly happy every single day. And again, we have those challenges, but it inspires me to be a better person, because I'm not so sure that I would be so resilient if I had all going on what he has.
Awesome. Thank you, Alicia. So Melinda, in thinking about, if you're supporting a parent, which I know you've done many, many times through this process, how would you help them understand the differences, across the spectrum? So for example, I hear a lot of families say, but my son doesn't look like my neighbor who has autism, or my daughter doesn't look like my, what I thought autism was. So what are some ways that you have, talked to families about this, and how do you kind of help others understand autism?
That's a great question, Kristen. Thank you. Well, I think that I spend some time with each family, educating them and helping them understand what the spectrum is, and also pointing them to some resources that can help them look at the spectrum, and also help them to understand that their child is unique, and we can't compare our one child to another child. So I think it's pointing them in the right directions to resources that can help them look at that more and see what the spectrum looks like. And this webinar will do also a wonderful job at helping families look at that spectrum and the variety that there is in different people who have autism.
Awesome. Thank you. So in thinking a little bit about, what I do in clinic, and I take care of, I get the luxury of both doing a lot of diagnostic work and then taking care of them for the rest of their, young adult all the way through mid-20s. And so I might diagnose a toddler, and then now I still get to take care of them in their mid-teens. I can give you a little idea of how long I've been in practice. And so, thinking about all of the things that I've seen over time, sometimes I find myself diagnosing somebody who's in their teens for the first time. So they may come to me with multiple other types of diagnoses first. And so I know that can be pretty tough, because the rates, if you will, of other diagnoses first before landing on the autism explanation, the right answer, if you want to think about it that way. I mean, and of course that's up for discussion, can be really tough. And so Val, help us think about this. If you've got somebody who comes to diagnosis late, I've had some people ask me, well, what difference does it make if they're already an adult? What would you say to that? And help us think about, in the context of diagnosis, how do we consider an older child, if you will, or even an adolescent or an adult who's coming to diagnosis, and how we work within other diagnoses that may have been given prior to an autism diagnosis?
Thanks, Kristen. I think that's a really important question, because I was just actually talking to a mom this week whose son was diagnosed at 19. He's now 23. And he's struggled most of his life. He was diagnosed with ODD. He was diagnosed with, which is oppositional defiant disorder. He was diagnosed with OCD, obsessive compulsive disorder. He was diagnosed with ADHD, attention deficit hyperactivity disorder. He was diagnosed with anxiety disorder. And I'm not sure if I'm forgetting one more, but I know those 4 for sure. And he was put through treatments that were specific for these different diagnoses. Most of them included medication. And of course, he wasn't responding to any one of these well. And instead of questioning whether this was the right diagnosis, they were questioning whether it was the right medication. And so what they were doing was changing the medications and the medication dosages, but they weren't really looking at all of these things. Well, maybe it's not one of these, and we're talking about something that really captures all of it. And this is really, unfortunately, the story of a lot of adults that come today to, young, older teens, young adults, and adults that are seeking an answer to things that they've noticed themselves or their family members have noticed have been struggles for them for their entire life, and they just haven't had the right answers. And so it's crucial to get a good diagnosis. This individual himself, his mom was saying that when he actually got the diagnosis and read what it meant for him, it was the first time that he felt understood. He looked at his mom and said, you know, this explains why I've been having so many difficulties all these years. And his mom felt terrible because she was saying, you know, like, I would have done things differently. I would have, you know, so many times I felt he was doing things on purpose. And it was purposeful, and it wasn't. He just didn't have the skill set. And had we understood that, we would have been able to help him develop that skill set. So now at 23, he is finishing college. It's been really challenging. And she described it as a very challenging process. One, because she didn't really find the appropriate supports for him. But then two, also, he's developed a whole lot of kind of bad habits, right, over the years, because he hasn't had an understanding of himself. And those bad habits have really gotten in the way for him. So it's extremely helpful to get the right diagnosis, get that as quickly as you can. And if you are an adult or a teen or a young adult that really hasn't had a good explanation for why things don't go the way, you know, you have something that you think is going to be the right plan for a situation, and then something goes awry and you're like, why did that happen? How did that happen? You know, having a good explanation for that is only going to help you. Because of that, many, you know, we talked a little bit before about things, diagnoses that are co-occurring, meaning that they're happening at the same time as is ASD, as autism spectrum disorder. And one of the largest comorbidities or coexisting conditions is anxiety. And in particular, in individuals like this young man that I'm telling you about, because he spent so much time trying to figure out why things don't go the way that he you know, thinks that they're going to go. And so that causes a lot of anxiety because you don't know how to fix it the next time. And so that could also lead to depression and, you know, depressive symptoms. And so it's really important. And this is going to be part of an evaluation of, you know, a teen, a young adult, or an adult. Are these other aspects that may have developed that are coexisting and are very common, in particular in adults that are quote unquote higher functioning, meaning that they have more language and they have more independent skills, yet they're still, you know, having trouble maintaining a job. Because they don't see the things that they might be doing to contribute to being fired every time they start a new job. So they may have the skill set, they may have the language, they may have the intellectual ability, but it's these soft skills, right? Knowing how to manage certain situations and knowing how to manage, for example, my rigidity or my need for a routine, and that others may interfere with that and I need to be okay with it, or I need to develop a plan around that, right? But if I don't know that about myself, then it's really hard to develop those kind of strategies to help myself out as an adult. So it's really important and crucial that adults and especially young adults who have gone through this unfortunate, you know, accumulation of diagnoses over time, and not one of them really explains, you know, what this mom was saying is that I would read what these diagnoses were, and I would say, yeah, he has some of that, but that really doesn't explain this other stuff. You know, like, how do you explain this other thing that happened? And so it never really fit for her, and she never, you know, she was going along because she didn't really know. And she's a physician herself, mind you. This is not about education, you know, but the challenge there of just not knowing how to put it all together.
Absolutely. Well, I think those are really important points. And I want to highlight for everyone that, you know, today's webinar is all about how do we help support our broad understanding of what is autism. So we talked a lot about the symptoms of autism. We talked a lot about and showed examples of some of those social communication skills in little itty bitty kiddos. And yet it's a broad spectrum, right? And so I think we will all be well served to put our assumptions aside and learn more. Get to know somebody who has autism. Get to know your own Sam. Get to know your own someone who is, I guarantee you, not far from you, who has an autism spectrum diagnosis, because they are incredible people who have so much to offer us and so much to teach us about not only who they are, but who we are. And so there's so many things that we can learn when we put our assumptions aside and think more about what they have to offer than what they can't do, right? So today was a lot about understanding and a lot about helping us to think about what autism is, and then also how we look at how we decide if someone does have this diagnosis. That's a really important piece. Taking those next steps to move someone forward, to take action, to learn about treatment, to get into the right resources, all very critical, because that's how we can move people forward in leading their best lives, living their best lives, finding those communities, and being a part of a community where they can do the things that they were meant to do, right? And again, that may look very different as it does for all of us. Every single one of us was built to do something, right? And so what that something is, nobody ever just is born and you know exactly what that looks like, right? So it's an opportunity for us to continue to grow. And I think that these ideas of high functioning, low functioning, affected, seriously affected, Rain Man, all of these things need to be set aside because each person is unique. Each person with autism, each person without autism. So setting aside those assumptions and those frankly biases, really important for us to grow in our understanding and to grow in the way that we understand and accept each other and accept all of us who can have abilities to continue to grow. And so I'm so thankful to all of you who are listening. We definitely have lots more to continue to learn. And I think digging into this idea of adults and young adults and how we continue to grow together is super important. So we will be definitely coming back to that. But for now, we are so thankful for all of you. And I'm thankful to this incredible team that I get to work with. And we will see you all soon. Thanks, everybody.